you so much for the kind introduction. First of all, I would like to thank all the Versa family, and indeed, I feel like I'm at home here because we are a big family together. And especially, thank you, Salah, for changing my entire professional practice in the last 5 years. And it all happened in Vegas, I think, 5 years ago, when this gentleman came to me with a dear friend of mine, Paolo Trizzi from Italy, and Paolo was pointing, look at those drills. And Salah came over and he said, well, you know, I wanted to approach you a long time ago, but I was afraid because you are Israeli and I'm Syrian in origin, and I thought you wouldn't like to speak to me. So I said, well, let's give it a try, and ever since we speak on a daily basis. We are real brothers. So thank you, Salah. So the topic of my presentation, and also thank you, Mike Picos, for being my warm-up, especially in this sinus arena. So we'll start first with two topics. I will address the posterior maxilla related to osseodensification, and we will touch upon ridge expansion in atrophic situations. And I looked over my presentation a couple of years ago, and I took all those cases out and brought some new stuff here to the table, and some of it is a little bit outside the box stuff. Like Nelson was showing outside the box, I would simply advise you, please, some of those procedures don't do on Monday morning in the office. Still, you need a little bit of experience in order to do those. So we know that posterior maxilla lacks teeth, and approximately 42 million adults in the US, or more than 20% of the population, are missing posterior maxillary teeth. And we know that the maxilla is 35 times more frequently edentulous than the mandible. And what happens when we extract a posterior maxillary tooth, we get resorption. And the resorption comes both from the crest, from the buccal aspect, and also from the inner side of the sinus, what we call pneumatization of the maxillary sinus. And at the end, we end up with insufficient bone height to place our implants. That's why sinus augmentation was advocated in order to create bone in the posterior maxilla, to achieve osseointegration in that bone, and of course to maintain the occlusal function under load with high predictability. And there is a big paradigm shift nowadays regarding posterior maxillary rehabilitation using sinus augmentation procedures. Now, I looked over the literature to see what have I contributed to sinuses regarding articles, and I was really amazed to find out more than 34 articles that I was writing or being part of, and the one I'm mostly proud of is the last one that just published a month ago together with Salah, Howie, and Rodrigo, on osseodensification doing subcrestal sinus augmentation. So let me go with you just very quickly about my evolution in sinus augmentation. And here I want to thank two of my mentors. On the left is Steve Wallace, which I've been doing some sinus courses in the last 10 years. And on the right, the godfather of sinus augmentation, Hill Tatum. And we will talk about the evolution regarding three aspects: the approach, the instrumentation, and the graft materials. So let's go back a little bit to the past. 1997, that's 21 years ago. I was a big fan of lateral windows. So we were taking this type of situation. We created a big oval window with our surgical burrs. Then we grafted with this unorganic bovine mineral. We covered it with a membrane, And then 9 months later, we came back in, we placed those fixtures, and 6 months later, we were able to finalize the prosthesis. And here you can see that case 21 years or 20 years down the road. And by the way, you can see a little bit my evolution in implant dentistry with those different implants inserted. And when we look at the pre-op CBCT, the one that was taken 9 months post-op, and the same cut that was taken 20 years later, we see that this is a long-lasting treatment modality with a high success rate. And when we take a look at the histology, we see that those black particles, of course, will not be resorbed, and they are interconnected with some new bone formation. But we all know that lateral window involves also complications. And those of you here who are doing lateral windows know exactly what I mean. And here you can see some of the complications that I had during my years of doing lateral windows. And of course, you have to be very careful also during the surgery not to hit those blood vessels. Otherwise, you have to warn your assistant. It comes from one side of the room to the other. So, what is the alternative? And by the way, those animals here have something in common. They are extinct animals. And to my opinion, lateral window will be an extinct procedure in the very near future. Everything goes today to minimal invasive procedures, not just in dentistry, in orthopedics and in other medical fields. And that's why we were looking for some minimal invasive approaches to the sinus. And I've been lecturing on this minimal invasive approach using a balloon in order to elevate the sinus for quite many years now. And this is one of the ways how to avoid a lateral window and go from the crest. And here you can see all kinds of burrs that were manufactured to get to the Schneiderian membrane safely, and the balloon approach, which lifts up the membrane. And you can actually see that the membrane stays intact, and then, of course, once you elevated the Schneiderian membrane, there is no problem in placing your graft material. And in this particular case, this is one of the graft materials that I really love because of its delivery system, and also it fills up the sinus maybe in 20 seconds. And that's Novabone, which is a synthetic material, calcium phosphosilicate. So those are some of the publications that we put up in the dental literature regarding this minimal invasive approach using the balloon. And you can see a typical example of a case that requires sinus augmentation, and instead of going laterally with a window, with all the morbidity which is involved, we went through a crestal approach, utilizing the balloon technique, inserting the graft material and the implants at the same time, and you can see the post-op and the 7-year post-op of that particular case. But all of us, we want to create more with less. And that's when osseodensification comes into the picture. And that's a different ballgame. And osseodensification, as all of you know, is not a procedure for doing sinus augmentation. Osseodensification is a procedure for implant osteotomy preparation, increasing the primary stability of our implant by doing compaction autografting. Now, what is the most problematic part in closed crestal sinus augmentation? Definitely maintaining the Schneiderian membrane integrity. So I call osseodensification smart, and I'm not competing here with other systems or approaches, okay? Why smart? Because it's simple, it's minimal invasive, it's atraumatic, repeatable, and time-saving. Here you can see Nelson Pinto's, one of my dear friends, famous video of how he applies those denser burrs against PRF membranes. And by the way, you can see on the left, I'm so smart, I changed my password to incorrect, so when I so when I get my password wrong, it says your password is incorrect. Now, you would say, well, PRF membrane maybe is a different ballgame. So I took one of my patients and I went through with my denser burr inside, right to the Schneiderian membrane. I know it's not allowed, but I went 7 millimeters deep and we had a 4 millimeter ridge. And I made a lateral window just for you to show that the membrane stays intact. So let me share with you my first case of osseodensification, sub-crestal sinus, and that was right after I met Salah in Vegas. So this patient here presented with, on the right side, with a failing premolar, this one. And immediately when you are doing your treatment plan, you have to think about what kind of provisional restoration you can give the patient. So I decided here to use the distal tooth, which was quite okay, and to do an immediate socket implant at the place of the extraction and combine it, of course, with 2 adjacent implants and sinus augmentation. So I looked at the cone-beam CT. I had about 4 millimeters of height, and I had a huge defect on this premolar, right there. So I went and did the Sinus Protocol, and those of you who are not familiar with the protocols that we have designed, please come to one of our courses. And I extracted the tooth, and I'm a big believer in green dentistry. So we take the tooth, we grind it up, sterilize it, and bring it back to the patient as an autologous graft material. And Nelson was showing some beautiful stuff with the dentin grinder. So we are doing our sinus, we are doing our immediate socket implant placement, and then we go ahead, we place the membrane in the buccal aspect of the premolar to create the buccal bone deficiency. And you can see here that's on the left immediately after the surgery. You can still see the reaction of the Schneiderian membrane to our surgical manipulations. And that's right over there. But on the right, you can see a 4 months post-op of that particular case and new bone formation. So here it is. All implants are embedded in newly formed bone, befores and afters. And that's a 4.5-year post-op of that particular case with a post-op CBCT. So again, I would say long-lasting treatment modality. Upper left maxilla. No doubt we need sinus grafting. So we go from the crest, utilizing our VersaBurrs. And here we were all brought up when we did our implantology courses that there is a primary stability and there is a secondary stability. And 3 to 4 weeks is where the deep point is, and that is the crucial time where the implant is not that stable. Well, we checked stability of our 2 implants, which was remarkable, 76 and 75. And look what's happening. 1 week, 2 weeks, 3 weeks, and 4 weeks. Stability remains the same. So maybe this graph here of primary, secondary stability is not valid for osseodensification. That's why we can load those implants much quicker. So here is that same case 3.5 years down the road. Upper first molar. No doubt, this is a goner. We need to extract it. So we extract it and we use the septum. I'm sorry, I'm not tapping the septum up. I'm utilizing the septum as my site for doing both expansion and augmentation, sinus augmentation. So we go step by step. You can actually see the bone which is pushed up against the Schneiderian membrane. And here is this beautiful slide that shows you the osteotomy. And then we apply the graft material, which was nova bone here. And the implant follows with a nice post-op CBCT. This case here was done the day before yesterday, the day before I came here. Just showing you here extraction of this molar, utilizing the septum as the site where we are about to lift up the Schneiderian membrane, using the pinpoint drill of Versa, which is a 1.3 in diameter, and then go sequentially and expanding and elevating the Schneiderian membrane. Once we elevate, we are ready to insert our graft material, followed by, of course, implant placement. So I'm injecting the graft material here, propelling the graft up with the osseodensifying drill, placing the implant, covering it up, checking stability, 79, not bad. And you know, from 68 and above, you can immediately load. And here is the post-op. Well, who would like to do a lateral window right there when you have a very thick buccal wall? You can do it. It will take you 45 minutes just to design your lateral window. And by the end, you lift the membrane up, it will probably tear. So what can be easier than going with osseodensification burrs from the crest, lift up the membrane, inject your graft material right there, straight into the osteotomy, and then place your implant, check stability, which is remarkably high in a 4 millimeter existing residual bone height. And then, when you take a post-op radiographic picture, you see the entire picture. But only 4 months later, when I take the post-op CBCT, you see new bone formation all around the implant. You don't see the nova bone anymore here. And that is the same case 4 years later. Long-term stability. What about sinus slope? Now, those of you who are fans of tip-tap know that if you have a sinus slope and you want to elevate the sinus membrane, 95% of the time, I can guarantee you membrane perforation, even if without knowing it. That's for sure. The only way that I know today to overcome this sinus slope, of course, except for doing lateral window, is to use osseodensification. And this was done by one of my students in Lisbon, Portugal, Dr. Gasper, and he sent me this beautiful picture of the sinus slope with osseodensification preparation. Here I brought you another case, upper left, needs of course sinus augmentation. I created here a lateral window for demonstration purposes only. Not that I wanted to lift up the membrane from the lateral aspect. And then I went from the crest. I'm evaluating different types of graft materials. So here I used a relatively new graft material, which is called Ossix bone, and Rodrigo was mentioning and showing it in some of his cases. And I lift up the material again with my denser burr. So you see how implants now are inserted, checking stability, again, quite high stability for those implants. And of course, we utilize also PRF in all our regeneration procedures. Here is the post-op. 4 months later, uncovering final restoration, and a 2-year post-op. So let's move forward. Here is another challenging case. Upper first molar needs to be extracted. Both premolar and molar on the other side, again, are for extraction. So we need sinus augmentation on both sides. So what I decided to do, and you can see the pre-op CBCT here, is to go ahead, extract those 2 teeth, and of course, green dentistry is the bottom line. We prepare the teeth, we grind them up, and we use them as our autogenous graft material. Then we go with the Versa burrs, crestally, place the implants, check stability, exactly as I've shown you before. And on the other side, I extracted a tooth and did socket preservation using the dentin. Now, waiting for about 3 months, I came back in. You can see that there is new bone formation. Again, using the denser burrs to densify the area, do sinus augmentation this time by lifting up the newly formed bone over there. And here you can see the post-op CBCT of the left side and the right side. And again, this is repeatable time after time again. Of course, there is a small learning curve which you have to take into consideration, but it's much quicker than the learning curve of doing a lateral window. Again, my student from Portugal, a challenging case, doing it with Osseodensification, post-op CBCT, and here you can see nicely the graft material from the inner side of the sinus. Now, you will never know your limits unless you push yourself to them. I think there is something wrong here with the beamer because those movies are jumping, but I would never dare to do what those folks are doing. And each one has to be expert in his field or his profession. And like Howie is expert in socket shield, and Mike Picos is the expert in blocks, I think I know a little bit about sinuses. So I challenged myself with those extreme cases. And here is one of my favorite ones, a young lady that has aggressive periodontitis, and she's left only with about 2 millimeters of residual bone height, right there. So it was right after I saw Salah, and I told her, look, I'm not going to charge you for the treatment, but you have to give me the opportunity to take as many pictures as I can. She said, well, go ahead, do whatever you want. So I went ahead, I extracted the tooth, grinded it up, used that as my graft material for doing the osseodensification. And then placed my implants, 5 mm diameter implants, took periapicals during the surgery, and that's how it looks like after the surgery, the post-op CBCT. 3.5 months later, we did a prosthesis, and that's how it looks like. And fortunately, she came back a few weeks ago, 4.5 years post-op, with the post-op CBCT. Again, everything is stable. Now, the study that was published just a month ago in the JOMI was a multi-center study with 222 sinuses, 361 implants. Only 7 implants failed with a 97.9% of success, which is the same exact number in the literature for a lateral window and for an osteotome sinus augmentation. And that is from the JOMI from just a couple of months ago. Now, again, don't do it on Monday morning in your offices. But why not go flapless if we can? If it's that simple, why not? So here is a typical case. We have 5-6 millimeters of available bone. We go, we punch the tissue, providing we have enough keratinized gingiva, of course, and we do same protocol, Sub-Crestal sinus augmentation. Stability is high. I mean, there is nothing new except for the fact that it is done flapless. And you can see it with the final prosthesis. Another one here, which was quite a challenging one. This is a case I've done some years back, and at that time, my other brother, Dr. Horwitz from New York, came to my office. He was my assistant for that surgery. And I went a little bit wild because I was aiming to place a 13 mm long implant in a 4 mm ridge, done flapless. So here it is, placed Novabone as a graft material, checked stability, which was very high. And here you see the post-op radiograph. And there it is, post-op 5 months later and 3 years later. Here is another one. We have sufficient bone height of about 5 millimeters, 5 or 6. We go flaplessly with our osseo-densifying burrs, place the graft material, insert the implants, and you can see the post-op CBCT. Believe me, it became my easiest procedure in my office. I prefer doing that than a class 1. Now, I'm not sure about the videos here because something is jumping here, but let's try. So here is one of those flapless cases, the one I showed you. So you can see the step-by-step procedures. So you can see the canine is mobile, has no bony support, has a fistula. So of course we need to extract it. So here I used a new machine called magnetic mallet to assist me with the extraction. That's the tooth. We clean up all the granulation tissue and the remnants of the soft tissues. It has to be very clean. And then we punch the tissue to get to the underlying bone. So the first two implants are not related to sinus. They are simply osteotomy preparation done with osseodensification. So you see the sequencing of preparation, everything in reverse, of course. I still remember my dental assistant, the first time I did osseodensification, she looks at me and says, "Hey, doc, that's the opposite way." I said, "Don't worry." And once you use those drills, you know that they don't chatter. So the place you do the osteotomy, that's where you are. You are not shifting. So we make those parallel, and we can insert those implants now. Now, it all depends what is your torque force in your units. Mine is like 55, so it stops at 55, and I know that I have to go manually now to insert the implants. Now I check stability. 80. So I'm very pleased. Put a second one. And of course, I will graft the buccal aspect. "75 or 76. Now we go to the sinus. So we do a flapless approach, taking out the soft tissue, exposing the bone. So you see very nicely the bone that lies underneath. I start in reverse. And I check. I always check, and I get the resistance that I can feel, the Schneiderian membrane and the bone that was present there. Here I was placing an allograft. That's Mineros. Injecting it with some type of a bone syringe, and propelling it up with the osseodensifying drills. Repeat for about 2-3 times. Usually, you don't need more than a half cc per site. And I'm using this ScanMate that was designed for scanning as my surgical retraction tool. Patients love it because it's not made of metal, it doesn't have sharp points, and in any surgical procedure nowadays, I use it as my retraction tool instead of using a mirror or a retractor. So we go to the second site. And actually, I didn't really cut the video, so you see that goes very, very quickly. So once we finish up with the grafting, we are ready for implant insertion. And you see there is no messing around with bleeding, with retraction of flaps, with potential hematomas afterwards, no vertical incisions, nothing. And as a matter of fact, when I call up the patient the day after, they think that you are God because they didn't feel anything. So implants were that stable that I've decided also to do immediate loading here. So we still have a tooth here. We are placing stock abutments here. And I'm going to load those implants at the same time. So we have a prefabricated temporary bridge beforehand. Of course, we are grafting the buccal aspect to prevent recession. Okay, let's run forward. Now, this is part that's a surprise for you, Dr. Paul. This is part of a study which is going to be submitted soon on flapless sinus augmentation, done in 2 centers, Dr. Snezana Paul in Croatia, that you will be hearing tomorrow, probably a fabulous lecture, and myself, and we have 73 cases, sinuses treated, 111 implants, and as you can see, the success rate is very similar to what I've shown you before with all other treatment modalities. But again, it looks to you maybe very, very simple, but it requires a little bit of experience first. Now, if you think that that was outside the box, take this guy here. He suffers from a genetic syndrome named Gaucher, which affects all kinds of internal organs and the bones too. Now, here on the upper maxilla, somebody has resected a distal buccal root, but this tooth had to be taken out. It was very mobile. So I took it out, and again, I applied the concept of sub-crestal sinus augmentation through the furcation area. I applied my favorite graft material here, Novabone, lifted up the membrane, placed the implant, some Novabone to fill the gap, closed it, healed beautifully, and here is the post-op. But I didn't bring that case here to show you the upper maxilla. Because what I've done here, I've done sinus augmentation in the mandible. No, I'm not kidding. Sinus augmentation in the mandible. Because look, that, by the way, is the post-op radiograph of the upper. And here is the mandible. Polycystic, completely empty. Looks frightening, I can tell you. And the problem was that he's going to lose this molar here. And I scratched my head and I said, well, what am I going to do here? Take a look. So I look very carefully, I bang my head a bit, and then I decided, well, I extracted the tooth, did a little bit of socket preservation, and went back 2.5 months later. And I went flapless. So you see that the cortical aspect of the ridge healed. And then I started with my Sinus Protocol. Exactly as I do in the maxilla, I do in the mandible. Because I don't want to touch those cysts. I don't know what's inside, probably nothing. But I don't want to bring up some new problems. I check stability. Insertion torque is more than 70. Stability was very, very high. I was very happy, of course. Healing was uneventful. And I was very curious to see what will be the post-op result. So here it is before the extraction. Here it is after the extraction. So you can see we are missing here a lot of bone. And here is the post-op result. 11 millimeter long implant with osseodensification. I was very happy. So I think that is the first ever described sinus augmentation in the mandible. And he's about to be restored in about 4 weeks. Now, that is for sinus augmentation. Now let's move to the other subject, which was ridge expansion. And one of my dear friends, which is part of the scam to get me into osseodensification, Paolo Trisi, published in Implant Dentistry a nice study done on sheep on ridge expansion done with osseodensification. And what he was able to show is that osseodensification performed much better than regular and standard drilling. And not only that, that when he took the measurements, he found out also that the bone volume was way much more than the bone volume that he got with conventional drilling. And when we took the histology, he told me, look, I've done histology for more than 30 years, and that is something I've never experienced before. New islands of bone formation all around the implant threads, exactly at the places where osseodensification had been done. And he published that in Implant Dentistry, and he was even able to show that in the test group, the micromotion was reduced by 50%, promoting, of course, osseointegration. So let's see what we can do in ridge expansion utilizing osseodensification. Some of the previous lectures already have shown the use of osseodensification burrs in the septum. So here you can see a typical example of expanding a septum and coming from a 2 millimeter septum to a 4 millimeter diameter osteotomy done with osseodensifying drills and placing a 4.2 diameter implant with high insertion torque and very high stability. And restoration after 6 weeks. Here is another one, and I brought this one just to show you the beautiful osseodensifying ring here that goes from 2 millimeters to 4 millimeters, and then an implant is inserted, and of course it's not implant related, and the post-op CDCT. Now we are talking. That guy comes to my office after visiting several other offices, and he says, well, I don't want you to touch my sinuses. I have a neighbor that had sinus infection. Nobody's going to touch my sinuses. What can you do? So I'm looking, I'm scratching my head. Well, yes, we can do like Master Howie is doing, Curie technique to build up the horizontal dimensions. We can use bone blocks, right? But what is the main problem here? What kind of temporary restoration you would give that patient? If you give that patient his existing denture, you can kiss your graft bye-bye. So I said, well, let's try osseodensification. We have trabecular bone inside? Yes. Can we utilize it? Let's see. So I designed my treatment plan with a 3D planning and a surgical guide. And when I opened up the area, I wasn't that surprised to find out that I have a 2 mm knife edge ridge. So I started with the magic, doing osseodensification. And as you can see here, the ridge starts to open up really nicely, right here. And also right there. Both buccally and palatally. And if you are looking very, very carefully, you can see that there are no buccal fenestrations, no cracks like we had with those manual expanders. And actually, I'm placing a 3.75 diameter implant in a 2.5 millimeter ridge. Veneer grafting, thanks to my dear friend Nelson, he calls it hard PRF block, right? Or dense PRF block. So we are doing veneer grafting on the buccal aspect, cover everything with PRF membranes, and we are ready for impression taking. So we take impressions, and I'm transforming his existing denture into a fixed bridge, meaning that we have a metal-reinforced screw-retained bridge, and we left only the 6 anterior implants from his existing denture, so nobody can notice any change in his profile. That's how he goes after the surgery, and with the screw-retained temporary restoration. In 2017, let me share with you this case, which is, I think, one of my most difficult cases. That lady is hopeless. She had been to so many offices. Everybody told her, look, you have to adjust to your dentures. There is no way you can get implants here. Let's take a look. What's happening here? There is no bone here. Knife edge, ridge, no bone there. Exactly the same here. And also on the left side. Well, looks like maybe mission impossible. So what are we going to do? I look and I say, well, is there anything I can do for that patient? I'm looking very carefully on the CBCT, and then I decide, well, I have nothing to lose. I have a secret weapon, which is Salah's invention. And I can see Salah, he's now scratching his head. Salah, I told them not to do it on Monday in the office. Don't worry. And as the famous boxing champion, Muhammad Ali, once said, impossible is just a big word thrown around by small men who find it easier to live in the world they've been given than to explore the power they have to change it. Impossible is not a fact, it's an opinion. Impossible is not a declaration, it's a dare. Impossible is potential, temporary. Actually, impossible is nothing. So maybe we can turn the impossible to possible. So my outside-the-box thinking was, if I can place 6 implants in the anterior jaw and use maybe the tuberosity area by osseodensification and deliver the patient a temporary fixed restoration, then of course I would do sinus grafting, I would do nasal floor elevation, whatever you have seen over the years and whatever Mike Picos was showing so beautifully over the years. But I need to give her some kind of a temporary restoration. So maybe that will help me. So I called up my dental technician and I told him, look, on Friday we have a very difficult case. You have to be prepared for immediate loading. He tells me, well, send me the x-rays first. So I'm sending him the x-rays. He calls me and says, you are a lunatic. There is no way you are placing implants here. So I told him, look, come over, let's see. So I open up the ridge, and actually you can see what we are dealing with. Very, very narrow. All the way from top to bottom, almost. So I start first with the easy parts. So I'm doing lateral augmentation here because I want to place implants in the future, so we need to add a lot of bone. And we lift up the membrane, and then I go to the nasal floor and I lift up the nasal floor, again for the same purpose of placing longer implants. And then we start with the magic. And we always go slightly to the palate, and we do so mainly because we will not get resorption on the palatal aspect. And we know that because of the presence of the keratinized gingiva. And Jorge, you know that very well. And I'm able now to place those 6 implants in those osteotomies. Of course, there are narrow diameter implants, 3 millimeter, 2-piece. Here is the nasal floor, augmented, implants inserted, PRF blocks as a veneer graft and as a filling material, both for the sinus and the nasal floor. And I'm going now to the tuberosity area to start densifying the bone, filling up the sinuses, placing multi-unit abutments, and at that time and point, I look at my dental technician and he becomes pale because he knows he lost the bet. So we are using here a PRF block of allograft. It's like a sandwich technique that Rodrigo was showing in the morning, and this is covered with Volumax collagen matrices that ossify over the time. And you can see here, instead of doing a Curie compartment, we did that type of compartment. And now we suture up, we take impressions, and same day, the patient gets a fixed temporary restoration. So on the left, you can see the plan. Unfortunately, it was a very quick decision to do the case, so we didn't even have the time to do a surgical guide, so everything here is what Scott Gans calls brain-guided surgery. And here it is, the post-op panoramic X-ray. And if you think that that was bad, look at the lower jaw. Now, what the hell am I going to do here? Here is the nerve. Where is the bone? Well, I know some of my colleagues here would probably go maybe for lateralization or repositioning of the nerve. I try to do it as simple as I can, and I said, well, let's utilize the frontal area and place implants from mental to mental. So we do 3D planning of our future implants, surgical guide, identify where the mental nerve is, place your surgical guide, drill, and here I use the vertebrae in forward because we have a very dense bone. So don't be tempted to use them in reverse because you will lose the implants. Inserting the implants, high insertion torque, high ISQ values, so we can go for immediate loading. PRF block, suture everything up, take impressions, and this is one tip I can give you. You can use the orthodontic chain to connect your implants before you secure them, and then take the impression and get a temporary restoration, same day. So here is the case, upper and lower. And she is the happiest woman on earth. Now, probably you ask yourself, well, how does the bone look like 5 months later? Here is the post-op cone beam CT. So we go from distal tuberosity area to the sinus area, right there. Now we move to the front. Here you see the nasal floor elevation very nicely. We have a thick buccal wall, which is crucial for long-term stability. Now we go to the other side, and we see exactly the same. Sinus on the other side. And tuberosity. Now I will skip that video, but let's have a look at those x-rays here. You can see the post-op. And now I can place additional implants. So take a look at the ridge 5 months later. Remember what we started from, knife edge. Now here you can train a monkey to place implants. So again, we do osseodensification for osteotomy preparation. Salah, that's fine now to show them how you place implants in a big ridge, wide ridge, right? You see very nicely the osseodensification ring, placing a couple of implants on each side. And now I have a problem. I have too many implants. A good problem. So if I want, I can utilize them all. If not, I don't need to use all of them, especially in the front. Now, this is a nice article that was published 2009. Every surgical procedure presents advantages and disadvantages. Priority should be given to those procedures which are simpler and less invasive, involve less risk for complications, and reach their goals within the shortest time frame. I think this is what osseodensification is all about.
can be a dangerous place.
So those of you who would like to have some more experience are welcome to our new teaching facility, which will be opened in about 2 months in Tel Aviv. So sometimes in order to move forward, you need to go in reverse. And I thank you very much for your attention.